Welcome to this Section 89 Clinical Audit Explainer. We're skipping the basic definitions today and jumping straight into a high-stakes Socratic stress test. We are looking at limb-threatening orthopedic execution traps. Let's get right into it. Module 1 starts now.
Here's our Section 89 audit protocol. We'll be hitting Module 1, Intragomal Pressure Kinetics, Module 2, Neurovascular Shearing Mechanics, Module 3, Pediatric Fracture Physics, Module 4, the Executional Pearl, and wrapping up with Module 5, a mandatory validation drill. All right, Module 1, Intragomal Pressure Kinetics. So we start at what we call the judge's bench, with a classic 50-50 dilemma. Picture this. On one hand, you have deep vein thrombosis, or DVT, presenting with this dull calf warmth and localized tenderness. On the other hand, you've got acute compartment syndrome, or ACS, which brings tight, unremitting agony that is completely out of proportion to what you're seeing on a physical exam. Now, this is where the clinical lawyer gets trapped, right? They see a swollen leg, and reflexively, they order a venous duplex ultrasound. But doing that, you're missing the ischemic kinetics entirely.
The real tipping point here? It's severe pain elicited with the passive stretch of the compartment muscles. That right there is what separates manageable noise from a true impending ischemic crisis. You see, acute compartment syndrome is an agonizing tissue ischemia that absolutely will not respond to standard opioids. When you passively extend those toes and the patient screams, yeah, you've crossed the line.
And when you suspect that line has been crossed, you need a definitive signal. That signal is a delta pressure of 30 millimeters of mercury or less. That's your diastolic blood pressure minus the compartment pressure. Now, I want you to notice what is intentionally missing from this equation: palpable distal pulses. Pulses are preserved until very late in the disease spectrum. Listen to me on this. Pulses are just noise. Delta pressure is your actual signal. Which brings us to a catastrophic executional error. It's a genuinely dumb mistake, honestly. Elevating the limb above the heart in a patient with suspected compartment syndrome. Reflexively, you see swelling and you immediately want to elevate it. Wrong. Elevating that ischemic limb actively decreases the arteriovenous pressure gradient. You're basically fighting gravity to perfuse the tissue, which just further starves those already dying muscles of oxygenated blood. You absolutely must keep that limb at heart level.
Okay, moving on to Module 2, Neurovascular Shearing Mechanics.
For this, you must be able to instantly pair a structural failure with its precise neurovascular shearing counterpart. Its cause and effect. An anterior shoulder dislocation shears the axillary nerve, causing you to lose deltoid contraction. A posterior hip dislocation, your classic dashboard injury in a car crash, that predictably shears the sciatic nerve, presenting as a foot drop. And a tibiofemoral knee dislocation, that tears the popliteal artery, and that mandates immediate vascular mapping. Once you identify the vector, you have to operate within this severity invasiveness decompression matrix. So normal perfusion with an intact nerve, that allows for closed reduction under sedation. Equivocal perfusion, like maybe you have asymmetric pulses or an ankle brachial index of less than 0.9, that requires an immediate CT angiography, or CTA. But in ischemic crisis, like a pulseless knee dislocation with obvious limb ischemia, you bypass imaging entirely. That is immediate surgical exploration, no exceptions.
Next up, Module 3, Pediatric Fracture Physics.
Let's contrast these pediatric mechanical boundaries. On the left, we have radial head subluxation, commonly known as nursemaid's elbow. This happens after longitudinal traction, leaving the child's arm immobile in pronation. This is a completely benign traction injury. Contrast that with a displaced extension-type supracondylar humerus fracture. Blindly manipulating this kind of structural deformity is a critical error. Why? Because the sharp anterior bone fragment can literally lacerate the brachial artery or entrap the median nerve.
So what are our definitive interventions here? For the benign radial head subluxation, immediate physical manipulation via supination with slight elbow flexion is definitive, quick, and effective. However, for the supracondylar deformity, you have to immediately evaluate perfusion, get that arm placed in a splint, and proceed directly to urgent closed reduction and percutaneous pinning.
All right, let's look at Module 4, the Executional Pearl. Here it is. This is the single most frequent execution gap you'll see on the boards, and honestly, right in the trauma bay. You are presented with the pulseless knee dislocation. The absolute lethal mistake here is attempting to obtain a CT angiogram before performing an immediate closed reduction maneuver.
Think about it. If the limb is cold and pulseless,
the popliteal artery is very likely kinked or trapped by that dislocated joint architecture. So the absolute correct order of operations is immediate manual reduction. Try to fix the structure first. If the pulses do not return instantly post-reduction, well, only then do you bypass the CT scanner completely and head straight to the operating room for surgical exploration.
Finally, Module 5, the mandatory validation drill. Let's see if you've been paying attention. Read this vignette carefully. We've got a 28-year-old male presenting with excruciating right leg pain 6 hours after an intermedullary nailing of a closed tibial fracture. He's reporting a severe burning sensation on the dorsum of his foot. Passive extension of his toes elicits absolutely agonizing pain, but his distal dorsalis pedis and posterior tibial pulses are 2+, and they're equal bilaterally. So, are you committing to intervention here?
Honestly, if you hesitated for even a second, you failed. The key differentiating metric here is that agony with passive motion. And what about those palpable 2+ pulses? Like we said earlier, that is just clinical noise. The absolute action required here is an immediate fasciotomy within 6 hours. You have to restore that pressure gradient and prevent total muscle necrosis.
Let's consider one final vignette to wrap up. A 19-year-old football player sustains a high-energy hyperextension injury to his left knee. The joint is grossly unstable. Now, the distal pulses are faint, and the ankle brachial index is 0.72. Based on the scale we just audited, this equivocal perfusion demands immediate CT angiography. So I leave you with this cold challenge. Under extreme pressure, will you rely on comfort and clinical noise, or are you prepared to execute the absolute metrics of perfusion collapse? Thanks for joining me on this explainer. I'll see you in the next one.